TopMed Talk. Hello, welcome back to TopMed Talk. I'm Andy Cumpstey. We're going to talk about the Dreaming project and the Dreaming Toolkit. And it's a real pleasure to be joined by three people from the UK working with NHS England: Mindy, Dawes, Maria Oyston and Jane Murkin.
So I'm Mindy Dawes. I'm current Deputy Divisional Director of Nursing for Surgery here at Walsall Hospital in the West Midlands. And I was a NHS England Getting It Right First Time Nursing Fellow for Drinking, Eating and Mobilizing.
I'm Maria. I'm the Head of Nursing Service Delivery, Transformation and Resilience. I work in the Chief Nurse Office of the NHSE.
Jane Murkin, and I'm Deputy Director for Safety and Improvement Nursing in the National Nursing Directorate, and I lead on a range of national nursing strategic priorities around patient safety and quality improvement, and supported Zoe, Maria and Minty and the team with the design and delivery of the improvement collaborative called Dreaming.
What do we mean when we're talking about dreaming, Mindy?
So within the 24 hours post-surgery, having a drink, having something to eat and mobilising. Obviously, that means different things to different people according to their baseline. So we do need to modify for that. But it actually can cover the whole of the perioperative pathway.
That term dreaming is the acronym we're using for the drinking, eating and mobilising. But how did you first get involved with this work, and where did the interest in dreaming come from for yourself?
My background's actually critical care. So when I was working on the trauma and burns unit, a lot of our trauma and burns patients were losing a significant amount of weight because we would stop their NG feed for theatre. So there was a trial that they did locally where I was working at the time at University Hospitals Birmingham, which made a significant difference in the weight loss of those patients because the metabolism increases significantly for those groups of patients. Obviously, there are certain procedures that we did need to stop food for, airway-related or GI tract, but it did make a significant difference. So I was really keen that actually the muscle loss and the long-term effects on any age range of patients. So a lot of our patients were all adults, so 18 or upwards. No matter what age of the patient, they saw that significant deterioration, and it takes time for those people to get back to what they normally would do daily. And I saw the advert for NHS England GERF Fellow, and I thought, well, I'll have a chat with Zoe Packman, and it went from there, really.
So Maria, Jane, why was NHS England interested in dreaming per se as an area of focus?
Yeah, I think there were a couple of key drivers. So we do know that enhanced recovery pathways and previous work undertaken in this space is associated with better outcomes and experiences for patients. We also know that there's huge variation across the country in terms of how reliably that is implemented. And I think coming out of COVID and the challenges that we had in relation to elective recovery, this was actually seen as a real positive opportunity to contribute to the waiting list, see what more we could do to improve patients' experience and reduce lengths of stay and drive forward an improvement programme of work. Maria, what would you add?
Yeah, I mean, I think you've got it in a nutshell there. I think the importance around having the GERF Fellow for us as a nurse was really significant because usually the GERF Fellows are medics and nursing is not really a thing that's picked up by GERF Fellowship. So actually it was really great to see when I come on board that Mindy was already on board in that role there.
And for listeners who may be listening outside of the UK, the GERF Fellow is the Getting It Right First Time Fellow, is that right?
Yes.
So that's, if you like, a national role that's often been filled by a medical fellow, but not always. And it's great that Mindy's taken that role from a nursing background. But
Yeah,
you want to talk a bit more about what that role involves and what you were doing with the team?
Professor Tim Briggs has done a phenomenal amount of work around it. And I think I was really fortunate that there was myself and one other nurse with NHSE GERF at the time. So the first two nurses to be able to be offered this. And we had an MDT. So there were medics and AHPs at the table, and we met quite frequently online. But then we had some sessions in London where we had some leadership and some change management. And it was a real cohort, and we've gone on to be able to be offered to be GERF Fellow mentors in the future to support people through the process. So we wrote papers, we delivered our results. My role was slightly two arms joined together. So I was with the Dreaming Collaborative nationally with Zoe Packman, Jane and Maria and the team with lived experience partners. And then I had my GERF that joined in the middle. So looking at what could we look at to build on Oliver et al.'s work, really, with his seminal paper. And I think we showed the benefits for dreaming if your patient doesn't need 24 hours access to nursing and doctors, then they could continue that recovery at home. Obviously, there are those patients that have got a lot of complications or they're a bit longer in hospital. But there are, for the large part, a lot of elective patients that can go home and continue their pain relief and physio in a more comfortable environment for them.
And I was just going to add opportunities that the nursing directorate has liked to afford people in terms of Mindy coming in, getting an opportunity to learn about work from a national perspective, leadership development. And I think, Mindy, it's fair to say that probably has enabled and supported you with your career progression. So it's about investing in and supporting the future development of our nursing leaders.
You mentioned, Mindy, about the Oliver et al. Paper, and I guess that's for people listening at home, we'll put the link to that paper in the show notes so you can read that yourselves when you're listening to this. But you want to kind of summarise roughly what it talked about and why it was such an important piece of work for this area we're going to move on to talk about in a second?
Yeah, so Oliver and the team that co-authored the paper looked at numerous patient notes. The only surgical group that they didn't include within their work was the cardiothoracic patients. And they looked at the impact of when patients are post-op drinking, eating and mobilising, and the time scale within that. And what they found was patients who drank mobilised within 24 hours post-op had a significantly reduced length of stay by 3 or 4 days, really. And obviously we need to take that back to 2022 length of stay data, but absolutely proved the concept that actually, are we keeping patients in hospital unnecessarily?
Yeah, 3 to 4 days length of stay is a massive improvement. The key points in that paper, I'm going to read this out so I don't get this wrong. The editor's first 2 key points are, although enhanced recovery pathways have been widely adopted, implementation can be difficult and high compliance is variable, whereas actually a simplified bundle approach, such as the dreaming, drinking free fluids, eating a soft diet and mobilising within a maximum assistance of one person within 24 hours of surgery ending, can actually achieve a lot of the benefits we're seeing with enhanced recovery. This isn't saying enhanced recovery is wrong or false or not working, is it? It's just saying that over the years, enhanced recovery has become increasingly complex. Interventions are being added to that care bundle.
And you're right, Andy, in terms of the evidence is that the more elements to an enhanced recovery, the reduced compliance as such, because it becomes so complex and you've got multiple specialities in a ward environment where you're trying to obviously multitask and get everything right for those individual patients. So some of this is patient ownership as well and the education pre-op. But I think it's really key that it is complex, some of this, but as a little key bundle, there are so many barriers in place from an environmental point of view that actually if it was really simple, we wouldn't need this conversation.
Before we get to the toolkit, so the collaborative came first, didn't it? So why don't you pick up with the collaborative?
There's a huge body of evidence that improvement collaboratives can support people to reliably implement any key intervention. So it's the method by which you can implement something reliably. But what we wanted to do was kind of co-design it with people and make sure that it fitted the context in which they work. So I provided improvement expertise and support. We got a small group together. We thought about how would we look at this from a patient, and then Mindy talked about people with lived experience. We had some lived experience partners who actually had surgical procedures, so could bring their experience and what mattered to them from a patient or service user perspective. And we really designed an improvement program, which was to how do you implement dreaming reliably in different specialities, in different hospitals. And then Zoe, in her leadership role, went out through the regional structure to identify, really we were looking for interested providers who wanted to work with us, that had the kind of will and enthusiasm, who recognised that actually there was more that could be done. And we co-designed and delivered an improvement collaborative. And it's based on a model which is all teach, all learn. So over the time, we brought teams together. They were sharing their change ideas and their experiences. And that in itself created a community all focused on the same outcome.
Just for some context, I came into the collaborative quite late on. I'd previously been working in the London region for elective recovery, so I'd had quite a lot of kind of work around transformation and service improvement and innovation around bringing down wait lists. So when I came into this post under Zoe, it made sense for me to even just pitch on at the very last few months of it. I think just from a kind of observational, I was really impressed by the amount of trusts that were really keen and the engagement in that. You know, I know it was a really difficult time clinically, so I really prioritised that time, but it really felt like there was some great enthusiasm from the providers that were in, that they were doing something actually, and this was a surface improvement. So yeah, really interesting for me to come in that latter part. I suppose a lot of the roles since that is I've done an evaluation of how the collaborative went, what key things we found in it. I think it really matched the Oliver et al. Paper in terms of overall benefit. So we saw as well a decreased length of stay in our providers that were working in the collaborative, 2 or 3 days less than previously. And actually, and Mindy has done a paper around this, it had no effect on the 30-day readmission rate, because we did wonder, like, if we are getting people out earlier, could they come back quicker? But they didn't, which was a great result. We also got some really good feedback from patients and staff that they really understood what dreaming was now. And although it's what you think of as BAU, don't you, drinking, eating and moving, but actually having it in a structure and for them to really understand why it was so important was great to have feedback on that. What we really saw was a much bigger MDT approach. So I think traditionally, and, you know, even in my time, nurses do nurses' bit, AHPs do their bit, doctors do their bit. But what the collaborative really kind of taught was you can actually do a bit of each. So it's okay for a physio to talk about food. It's okay for a nurse to do some mobilizing. So it was really kind of great to see that MDT work together. And yeah, and working with the lived experience partners was great. They actually brought a real different aspect. From the beginning, it was co-designed with them. For me, I think all service improvement projects should include our lived experience partners, because otherwise we're teaching people to suck eggs, but not necessarily getting the right egg.
And just to add, Mindy touched on the role of the lived experience partners, and patients' families really have a huge role to play in dreaming. You know, if we enable them and empower them and give them the right education at pre-assessment, as Mindy said, then they know that actually it's fine for me to be drinking. Actually, I must be getting out of bed. And, you know, I think sometimes in our healthcare systems, we disempower patients. And it's a really important agenda that we make sure patients understand their unique contribution to this.
I think that's absolutely critical. And again, something the collaborative really did highlight and show, or 2 things actually. One, the important role of the lived experience partners, but secondly, as you've all touched on, that real importance of that full MDT approach. Actually, it's really important, isn't it, that everybody in the team is sort of working together to try and get patients drinking, eating and mobilizing, although there's still a surprisingly huge number of barriers to that actually being achieved in practice, isn't there?
When me and Maria were working on the evaluation, we found that we were detailing some of the barriers and looking at some of the solutions that the teams had put forward and been trialling through their PDSA cycle through the year, was that actually there are a lot of barriers that seem to be the same almost everywhere. But also then there are the cultural and some of the logistical barriers that perhaps an older build of a hospital have rather than a newer build. And then, you know, there's the enhanced post-op care units that have popped up in different hospitals, and, you know, they're usually in a theatre footprint, so they don't always necessarily have facilities for patients that are away, because most of us in healthcare would potentially know. But me and one of the lived experience partners, we delivered at Brian Dolan's deconditioning forum, and I think it's really important there, and the collaborative also highlighted this, that actually linking it with whatever you can, because there's nutrition and hydration groups, there's preventing harm groups, there's the medical deconditioning groups, and I think capitalising on those so that work isn't duplicated, including some of the information for patients, because obviously patients might see the whole raft of your services in each provider. So I think it's just aligning with everything so that we aren't duplicating work and making things harder for us or for our patient. And one of the key things I learned was how images that we put forward and how we word things with our patients, whether we are empowering or making sure that we're aware of their limitations. So, you know, getting out of bed for the most part, yeah, that's fine. But for some patients, that's never an option. So how can we word it so that we're inclusive and considering our patient a little bit less able to return to traditionally what is walking out to the ward.
Another thing that the Oliver et al. Paper highlighted really nicely, but these barriers, although they're individually quite small, together they can quickly add up. And as you, again, rightly said, the collaborative is a nationwide project with centres all over different regions taking part. And there are a lot of similarities to those challenges, but there are also a lot of individual centre variations. And that's where the idea of the toolkit came from, where there's a centralised package that anywhere could take off the shelf and had a sort of a starting point to get them started, but still helped them through these common barriers, common challenges. Is that fair enough?
Yeah. So Zoe Packman really was keen to really capitalise on the work that we'd done to share some of this learning more widely so that other people didn't have to necessarily put some of the background work in, and it was there for a pick up and use guide, and it did evolve quite significantly. Maria, do you want to?
So originally when we picked up the idea of the toolkit, we were thinking about how we enable kind of that sort of reward in terms of base it rather than the whole pathway. So we were just looking at the kind of nursing AHP element. And I think it was quite important to look at the whole pathway. So that started from everything pre-op through kind of your surgical, your anaesthetics, your nursing, so it just covered the entire pathway, which I think actually has made it a much stronger document. And there's some work in there that Mindy and Jane, as one of our main stakeholders, has kind of looked at in terms of what's the kind of organisational culture that you also need in order to run a service improvement, around like time, resilience, and the amount of staffing that you can kind of get to do these things. We wanted to make sure that there was something around the QI stuff, which Jane supported on. Just because it's strange, isn't it? You sometimes see clinicians that don't use any form of QI whatsoever when they're doing their service improvement, and sometimes they fall quite flat. So it's kind of key that you get that in there. But I think it's a much bigger package, Mindy, isn't it? Then, we thought this will take a couple of months. We'll just pump it out. But I think actually it's for the better that it hasn't, because I think it's a pick up off the shelf, isn't it? For someone that needs to sort out their dreaming in their provider. How do I do it? And what do I need to do that?
So this toolkit's been developed sort of in parallel to a surgery school's toolkit, which we've covered separately on Top Med Talk. And again, you can listen to Imogen Fletcher-Jones and Andrew Davies talking about that toolkit in that separate episode. But we should say that the processes were very similar, weren't they? So although they were done in separate projects, there's a lot of overlap, and they were done in parallel, working closely together. But again, it was a huge project, so a huge amount of work from everybody involved. But there was a lot of stakeholder meetings, involvement, lots of refinements over a number of months, kind of 6-9 months in the end, wasn't it? So a huge amount of work's gone in behind the scenes. But I think you're right. I think hopefully at the end, what we're left with is a document that everyone can be proud of producing, but also is really useful, not just in the UK where it was primarily focused. Potentially anyone around the world could pick this off the shelf and hopefully find relevance to their own institutions.
What was really good is that we were all able to bring our ideas to the table and discuss them openly, and what do we include, what don't we include, so that we don't end up with an encyclopedia full that nobody would ever pick off the shelf. It was, everybody's busy, time poor, and we need it quick, sharp and fast so that we can pick it up and think, I don't need that because I'm fully versed on that side of it. But actually, what do I need to do in terms of like our operational managers? What do they need to hear for them to buy into this? So clinicians and, all our healthcare providers usually are, we're here because we want our patients to go home, have a successful journey and go home in a timely manner. So how do we engage people that aren't healthcare professionals, that actually this is an investment, but actually in the long run, this is what we can achieve?
We had stakeholders from every background, didn't we? From surgeons, anaesthetists, nursing staff like yourselves, operational, organisational and management. It was really great to get all of those different perspectives and viewpoints. Should we summarise maybe? I mean, this document will be available very soon, as we said, for people to download and read for themselves. But
I can go through the organisational enablers, because I think actually before we even get anywhere, we need our organisation to buy into this. And what was found in the collaborative was that you could really see those trusts where every layer of the organisation had bought into it and was supporting it and being vocal about dreaming. So some of it's around infrastructure for patient education and engagement. So using your patient advisory groups, engaging them really, really early so you can build that relationship. Obviously, financial considerations won't be a surprise to anyone. Some project management. So some of our collaborative teams had a certain number of hours dedicated to dreaming for project management. And that really did a lot in terms of motivating the team, seeing their impact that their changes were having. Facilities in terms of surgery-specific wards and hubs, so EPOC, like I mentioned before, some of our providers have EPOC, and then the measurement which links in with project management in terms of obviously having that data set so that people can have a tangible, not just to report to the chief execs for the organisation, but to report to the team within, so they can actually see month on month the impact that their work is having, the extra effort that they're putting into this change for a lot of them.
I think it was important as well that we brought in some case studies. So we had 3 of our providers put case studies around kind of the collaborative, what the benefits were, what challenges there were. Because for me as a clinician, I always know if I can see that someone's done it in a set way and that's what's happened, then I could possibly pick that up the shelf and go with that. Or as Zoe would always say, pinch with pride. It's become one of my top phrases, actually. But there's something around being able to see it there in black and white. It's worked in that hospital, so we could do it that way. So we had a few case studies, which I think was really kind of essential around that sort of organisational piece.
And from a nursing specific perspective, I mean, we do know, don't we, that nurses, amongst other members of the multidisciplinary team, but play a vital role, both in terms of healthcare and promoting health and preventing illness. So actually, from a nursing leadership and practice perspective, nurses have got a unique contribution here to make sure they understand the importance of dreaming, their role, but more importantly, to enable and empower patients and families. This really does lend itself to that proactive approach to achieve the best outcomes and experiences.
That proactive approach needs to be, as we've all said, all the way through the pathway, doesn't it? So again, and we should shout out to Joe Simpson and Ramli Munasinghe who helped me on the anaesthetic side here. But clearly, if we're looking after our patients in theatres and we're, bringing them round to recovery and they're still in pain and they've lost a lot of blood and they're feeling really sick, doesn't matter what happens after that, they're not going to be able to drink, eat and mobilise effectively. So, we talked about the importance of really good pain management and good antiemetic use perioperatively being key factors in this process, the importance of getting appropriate blood management strategies in place, use of tranexamic acid, use of cell salvage in theatres, making sure that patients arrive in recovery euvolemic from a fluid status point of view, all those sort of things. We actually do have big impacts in this length of stay benefit we're seeing. And I think it's also worth, we put it in the anaesthetic section, but it links to the organisational aspects as well, and also the surgical aspects, risk stratifying these patients. So not just identifying those patients who are at high risk of complications and needing potentially maybe high dependency involvement or going to an enhanced recovery area, but actually also identifying those patients that are actually relatively low risk and should be going through on day surgery pathways and moving to areas in the hospital where they're better able to dream, drink, eat and mobilise sooner and more quickly without the extra monitoring that an intensive care unit would bring, for example.
I think you've touched on a really important point there, the high dependency element. So obviously some patients might not arrive planning that journey post-op, but sometimes our patients need a bit of high dependency or intensive care post-op. Because of my background, when I first qualified, there were those patients that would be elective bowel surgery. But, naturally, as a human being, remember those patients that deteriorated and ended up needing ITU, or they'd be okay and heading towards being discharged to the ward and then would end up back in surgery and then to ITU. So the paper that I co-wrote with some of the colleagues in the Toolkit was looking at specifically colon and rectal surgery and that 30-day emergency readmission. So the data that we used was national so that we could determine that, say, somebody required that emergency surgery while they were in Cornwall, even though they had their original operation in the north, that data would be captured. And what we found was that as a nation, length of stay was starting to come down. We looked at the 10-year period, and actually our 30-day emergency readmission was also decreasing. So obviously, it's not huge numbers, but actually every patient is within that information. It's really important that we recognise that as a nation we're getting this right, that we're not discharging too early clinically, and that patients aren't having that emergency readmission within that month.
Absolutely. And I think it's really powerful data that we've got to show that as much as a safety outcome as anything else, but implemented effectively, this tool isn't leading to higher complications, isn't leading to more readmission rates. And again, that's something that our surgical colleagues are very hot on. We had a lot of surgical input to this pathway as well. Mr. Mark Cheatham led on surgical enabler side, and his team came up with a few more factors from their side as well. Actually, lots of overlap with the other areas we've talked about: appropriate blood management intraoperatively and blood loss limitation strategies, identifying those patients at higher risk, making sure the TXA is being given by the anaesthetic team, those sort of things, prioritising minimally invasive surgery where possible. Might seem simple, but actually do have such big impacts, such as making sure the urinary catheter does come out at the first opportunity and the IV fluids do get taken down at the first opportunity. And all that's really explained both before the surgery starts in surgery school environments and at every stage of the pathway therein. So a huge amount of work covered, lots of overlap, but I think hopefully something for everybody to pick up and take away.
We know, obviously, all of the operational and clinical pressures that are out there now. You know, we used to talk about winter pressures, but actually it feels like every day is a pressure in the NHS at the moment. So I think having the toolkit that can kind of guide you to where to start, because you know you've got to do something, but where do I even go with that? And I think what the toolkit does is it gives you a kind of really starter for 10 and guide around how you can do it within your own area. But I think it's really key that people do understand the benefits of it, because I think sometimes you can think, oh, well, drinking, eating and mobilizing, that's a basic thing. That's what you should be doing. We should be, but it's not. And there's something about really understanding that kind of, what does it mean if someone gets out 3 days earlier? Well, one, that means you can do more surgery because you've got a bed to put somewhere, and we can start bringing those huge wait lists down after COVID. But also, how much better for the patient? Let's face it, we all came into these jobs because we wanted to make a difference to people, particularly our patients and those that are unwell. It's a privilege to be in someone's world when they're sick. And if we can actually make a difference to them by getting them home 3 days earlier, because I know if I'm a patient, I'd much rather be sitting up watching a box set with a box of chocolates than I would be sitting in hospital for another 3 days. So it's a win-win everywhere, isn't it? That's the thing. And I think the toolkit shows the evidence around it, but also does give them that guide of like where to even start with it.
And Maria, when I listen to you frame that, I think back to some of the collaborative sessions where clearly we had to do quite a lot of myth busting still. So, you know, we think that drinking, eating, mobilizing is something that everybody's doing. And as Maria said, huge variation across the system. But actually, there are still a lot of people that think, oh, well, you shouldn't be giving people fluids, you know, and actually, should they be eating following surgery? So actually getting the evidence base to the clinicians. And I think that's what the toolkit's aim to do, isn't it? It's to support people who are very busy, who may not be experts in particularly perioperative care or caring for patients. And we know today that patients end up in all sorts of wards and departments due to some of the challenges we have across the system around patient flow. So how do we make it easy for our staff to do the right thing? How do we absolutely make sure they understand that when patients can eat, when patients can drink, and actually enable them to be up and mobile?
Yeah. I mean, I think just generically, any kind of change that you're making, you've got to win the hearts and minds. You know, since working in transformation for the last 3.5 years, and even in my head of nursing post prior to that, you just need to be able to get them to understand why it is that it's so important. Because we get a lot of this, well, we've always done it like that. But actually, that doesn't really cut it into today's society. We can't keep doing that. That's the thing. We need to have a change. And I think the toolkit does try to persuade and bring that hearts and minds on. And I know that Mindy and I have done quite a few regional talks, and we've been down to Leeds University around some of the recovery programs that they're doing. And it is just really changing that mindset around how we deliver that whole enhanced recovery pathway, and how actually key it is, Andy, to have that jigsaw puzzle connecting. Because as you say, we're not going to get someone mobilizing if they're in terrible pain. It's just, I think it's just putting the jigsaw together, that they don't just think it's their department to do one thing, and that actually that whole pathway feeds into each other. And I think the toolkit really lends nicely to that.
A bit like what I mentioned about engaging with patients, advisory groups and lived experience partners early. I think it's really key that all layers of our teams are engaged early. Some of our ward staff will have some of the ideas and some of the solutions, and that's one of East Lancs did a lot of work around food delivery and timing with catering and the ward, engage with patients around what is it that you like and dislike about our food. There are some different layers throughout an organisation that can support this work. Usually there's a lot of quick wins that can happen at ward level and theatre level, and obviously pre-op and pre-admission, that links with Sick Till Send initiative, linking it with each other so that staff don't feel overwhelmed. They're being asked so much every day. Patients have been quite sick, haven't they? And some staff perhaps don't still feel recovered from the pandemic. So it's trying to rebuild almost and evolve a more sustainable pathway for our surgical patients where it is deeply embedded. It doesn't change for a couple of months and then spring back to, oh, I didn't know we were doing that. And like Maria said, hearts and minds of everybody.
Fantastic. Well, that's a really strong message, I think, to draw this to a close on. Absolutely, hearts and minds of everybody here. We really do hope that this toolkit is useful for you wherever you are in the world. It'll be available online soon. There'll be webinars going around here in the UK to try and advertise and launch it as well. But wherever you are, please have a look, and hopefully you'll find it useful whether you're an anaesthetist, a surgeon or a manager. There's something for everybody. As always, thank you very much for joining us here on Top Med Talk, Mindy, Maria and Jane. It's been great hearing all your perspectives and views on this important bit of work. And for those listening at home, thank you for joining us at home too. You can find us on our website, on your podcast of choice, whether that's Spotify or iTunes or whichever, and on social media. And as always, please do, if you go onto YouTube, go onto LinkedIn, any of those places, do hit subscribe, do hit the thumbs up. It really does make a difference to us. And thank you again to our sponsors, who this year are BD and GE, without whom we couldn't keep bringing Top Med Talk free and open access on our website.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.